Welcome back to the Clinical Anatomy Rounds. I'm Dr. Khan, and today we're diving into one of my favorite topics because it's the difference between a patient staying in one piece or heading to the OR. We are talking about joint stability. Why do some joints, like the hip, stay put through a car crash, while others, like the shoulder, seem to pop out if you reach for the remote too fast?
It's a foundational topic, Dr. Khan. For those of you preparing for your board exams, remember that the textbook defines joint stability through three specific factors: morphology of articular surfaces, ligamentous strength, and muscle tone. We need to be very precise about how these interact.
Right, precision is great, but let's look at the why. Think of a joint like a trailer hitch on a truck. You want it to move so the trailer can turn, but you don't want it detaching on the highway. That first factor you mentioned, morphology, that's the fit of the hitch. Dr. Sarah, how does that look on an X-ray?
Well, clinically and academically, the classic comparison is the hip versus the shoulder. The hip joint is a deep ball and socket. The acetabulum is like a deep bowl that swallows the head of the femur. This mortise arrangement provides massive structural stability. On the boards, they often ask about which joint is most stable due to bony architecture, and the hip is your answer.
And on the flip side, look at the shoulder. The glenoid cavity is shallow. It's like a golf ball sitting on a tee. It gives us incredible range of motion, but structural stability from the bone is almost zero. Why does this matter clinically? Because it tells you exactly what's going to happen in a trauma. A shoulder dislocates easily. A hip dislocation usually requires a high-velocity impact, like a dashboard injury in a collision.
Exactly. Now, moving to the second factor, ligaments. These are the seat belts of the joint. They are fibrous bands that prevent excessive movement. However, Dr. Khan, there is a high-yield distinction here between fibrous and elastic ligaments that students always trip over.
Oh, tell me about it. Most ligaments are fibrous. They don't like to stretch. If you stretch them too far, they tear. Think of a nylon rope. But then you have the outliers, like the ligamentum flavum in the spine.
Correct. Most ligaments are dense collagen and do not return to their original length if overstretched for long periods. A great clinical example from our text is flat feet. If the muscle tone in the leg fails, the ligaments of the foot take the full weight. They eventually stretch out. The arches collapse, and you can't just snap them back. They aren't rubber bands.
That's a vital point. Ligaments are like the ultimate backup system, but they aren't meant to do the heavy lifting all day. That brings us to the third, and arguably most important factor, muscle tone. I call this the active guard of the joint.
And this is where the boards love to test you. Muscle tone is often the primary stabilizer for joints with poor bony fit. Take the shoulder again. Without the tonic activity of the rotator cuff muscles pulling that humerus into the glenoid, the joint would just fall apart. The same goes for the knee. The quadriceps are the reason your knee doesn't buckle every time you take a step.
Why does this matter clinically? It's the basis of physical therapy. When a patient has a loose joint or a history of dislocations, we don't usually surgery our way into tighter ligaments immediately. We strengthen the muscles. We train the active guard to work harder. If you want to be the doctor of choice for your patients, you have to explain that rehab isn't just about strength, it's about stability.
And speaking of clinical pearls, we can't skip Hilton's Law. It's a favorite for examiners. It states that the sensory nerve supplying a joint also supplies the muscles moving that joint and the skin over those muscle insertions. It explains why a patient with a joint injury feels referred pain or has protective muscle spasms.
It's nature's way of saying, hey, the joint is hurt, so I'm going to make the muscles around it freeze up to protect it. It's brilliant. But Sarah, what happens when we lose that sensation, like in certain neurological diseases?
That leads to joint destruction. If you can't feel the warning pain when a joint moves beyond its range, you keep pushing it until the articular surfaces are destroyed. It's a tragic clinical scenario that underscores why every factor, bone, ligament, and muscle, must work in harmony.
So to wrap this up, think of joint stability as a three-legged stool. You've got the shape of the bones, the fit, the ligaments, the ropes, and the muscle tone, the active tension. If one leg breaks, the whole thing wobbles.
Perfect. For the high-yield takeaway, remember that muscle tone is the most important factor in the shoulder and knee, while bony morphology is the heavy hitter in the hip. Ligaments are your limiters, but they are prone to permanent stretching if overworked.
Great session, Dr. Sarah. Next time you're in the clinic, look at your patient's range of motion and ask yourself, which of these three factors is failing? We'll see you in the next one.